Okay, so the topic of today's session is Grade Pro GDD. So by this time, I'm assuming that all of you must have some idea about what is systematic review and what is meta-analysis. So for a systematic review, just a brief introduction about systematic review and meta-analysis. So for a systematic review, you have to answer a specific research question based on pre-specified eligibility criteria in a scientific manner or in a stepwise manner. And for meta-analysis, you have to apply the statistical analysis on your combined data so that you can reach up to a clinical decision or up to a clinical conclusion. Systematic review deploys a systematic and refined search of the literature using a priori derived search strategy, and systematic review are initiated after the author identify a subset of studies with specific inclusion and exclusion criteria. Before starting the systematic review, you have to make a PICO question based on your research question. So what do you mean by PICO? PICO is your participant, intervention, comparator, outcome, and S stands for the studies. Let's take an example for understanding the PICO. Supposingly, we are giving an example is articaine is better than lidocaine in achieving the pulpal anesthesia in patients with symptomatic irreversible pulpitis in mandibular molars. So defining the PICO here, your population will be the patients who are having symptomatic irreversible pulpitis in mandibular molars. This will be your population or the participants. Intervention will be your articaine group. Comparator will be your lidocaine group. And outcome will be in the form of achievement of pulpal anesthesias. And here studies will be the randomized clinical trials. So what is grade? So grade approach basically focuses on two parameters. One is the quality of evidence and another is the strength of recommendation. Grade is grade of recommendation, assessment, development, and evaluation. So as I mentioned, it focuses on two parameters. One is quality of evidence and other is the strength of recommendation. Here, I would like to mention that quality, the authors of systematic review while applying the grade only constrain themselves up to the quality of evidence, not for the strength of recommendation, as strength of recommendation is given by the guideline makers or the health policy makers. These are the strength of recommendation is part for them people rather than the authors of systematic review. Now, what do you mean by quality of evidence? Quality of evidence means it is the extent to which one can be confident that your estimate of effect is correct. Here, I would like to mention two things. What is effect size and what is estimate of effect? I think in meta-analysis, both these terms has been covered, but I would like to revise here also. So your effect size is a measure that quantifies the size of benefit or harm of a treatment as compared to your comparator. An estimate of effect describes the magnitude of intervention effect in terms of how the difference between the outcome data were between the two groups. Simple in terms, I would like to mention here that what is the difference of results, what is the difference of outcome between the two groups will give you your effect size. Your effect size will be calculated while applying the meta-analysis, and this will determine your quality of study to much larger extent, your effect size. Let's take an example here. We will take that example only is articaine is better than lidocaine in achieving pulpal anesthesia in patient with symptomatic irreversible pulpitis. Supposingly in achieving the pulpal anesthesia, the efficacy of lidocaine comes out to be 40% and efficacy of articaine comes out to be 60%. So here your effect size will be 60 minus 40, that is your 20% will be your effect size. You can take another example over here. Supposingly you want to control the post-operative pain and for which you are giving two types of NSAIDs, that is A or B. So the efficacy of NSAID A, supposingly Brufen, in controlling the post-operative pain comes out to be 40%. And your efficacy of another drug, that is the B, comes out to be 70%. So your effect size will be 70 minus 40, that is your 30% will be your effect size. Next point, which grade focuses is on the next parameter, which grades used to focuses is the strength of recommendation. So by term, strength of recommendation means the extent to which one can be confident that adherence to recommendation will do more good than harm. Means your desirable effects outweighs your undesirable effect, and strength of recommendation is always made by the health policy makers or the clinical guideline panel makers, not by the authors of systematic review. Why? Because most of the authors of systematic reviews, they miss some important outcomes, or either they do not consider the beneficial or the desirable effect into account, or the preferences or the values of the patient and the cost of the treatment or the resources which are utilized in conducting that intervention or that study. That is why the strength of recommendation is always made by the guideline makers. The steps in our approach to make a sequential judgment is: number one, you have to first decide which outcomes are important or critical to make a decision. Number two, you have to look for the quality of evidence across these outcomes. Number three, what is the balance between the benefits and harms of that treatment? And lastly, you have to make the strength of recommendation. So, grade basically offers two parameters, that is the quality of evidence, and lastly to make the recommendations. Quality of evidence grade can be categorized into four categories. Number one is high, number two is moderate, low, and very low. So what do you mean by quality of evidence which is high? That we are much confident that our true effect lies close to the estimate of the effect. In simple language, we can say that if we further do any research on that particular topic, that will unlikely to change our confidence in the estimate effect. If it is moderate, further research was likely to change an important impact, will have an important effect on the outcome of the estimate of effect and may change the estimate, means may change our results. Low, further research is very likely to have an important impact on our estimate of effect and is likely to change the estimate. And very low, it means any estimate of effect is very uncertain. So first of all, we have to make a PICO, we have to frame our PICO. Then we have to consider which outcomes are important for making the decision. So in the grade, the outcomes are divided into three categories: critical, important but not critical, and of limited importance. And they have been divided into scale of 1 to 9, in which numbering 1 to 3 is given of limited importance, 4 to 6, the outcomes which are very important, and 7 to 9, the outcomes which are very critical for making the decision. Let's take an example over here to understand what do you mean, what I mean to say about the important outcome, critical outcome, or outcome of low importance. Supposingly, we are prioritizing the outcomes in assessing the phosphate lowering drug of renal failure and hyperphosphatemia. So, nausea in this case will be considered as outcome of low importance. And the mortality, hospital admission, and pneumonia. These are the outcomes which are very critical for making the decision. So one has to be very clear while making the recommendations that which outcomes are very important for making the decision, which outcomes we have to consider for making the decision. There are certain factors which can upgrade or downgrade the quality of evidence. So these are the factors which we will be discussing one by one, which can affect our quality of evidence. Number one factor is the limitation in study design or execution, means risk of bias, inconsistency of results. Third point is indirectness of evidence. Fourth is imprecision. Fifth is your publication bias. And there are certain factors which can enhance the quality of evidence. Number one is your large magnitude of effect, and number two is your dose response gradient. Now, considering these points one by one. Number one is your study design. It has been observed that it has been seen that has been conducted by various studies that the randomized control trial definitely will provide you high quality of evidence as compared to your observational and quasi randomized control trial or the case series and the case reports. Next is your risk of bias. I think this term has been used while there was lecture on meta-analysis or systematic review. What do you mean by risk of bias? Risk of bias is the likelihood that the feature of the study design or the conduct of the study will give the misleading results. And there are various types of risk of bias, that is selection, attrition, detection, performance, reporting bias. So studies which have low risk of bias with no serious limitation will definitely have a higher quality of evidence as compared to the study which have a high risk of bias with serious limitations. Next point that is to be considered is the inconsistency. Inconsistency means your unexplained heterogeneity. What do you mean by heterogeneity? Heterogeneity can be of two types. One is your clinical heterogeneity and another is your statistical heterogeneity. Clinical heterogeneity basically mean what are the potential source of differences in the population, in the intervention, in your outcome measurements, in your results. So when we are talking about the clinical heterogeneity, it means what is the difference in your clinical setup while conducting the study in the population intervention or outcome measures. And by the term statistical heterogeneity means what is the difference in your results, what is the difference in your effect size across the different studies. The statistical heterogeneity is denoted by I-square value, which will be given by your forest plot, and you can see through your forest plot your I-square value, and it is a rule of thumb which is given by Grade Pro GDT handbook. That is, if the heterogeneity is less than 40%, means the value of I-square is less than 40%, means the statistical heterogeneity is low in that. And if it is moderate, the value will be 30 to 60%, substantial 50 to 90%, and considerable 75 to 100%. Now, the indirectness of evidence. Indirectness of evidence. Definitely, if we are having direct evidence, if we are comparing directly the group A with group B, the confidence will be higher as compared if we are indirectly comparing group A with C or group B with C, then there will be the higher indirectness, means low confidence of confidence will be there in the estimate of the effect. And differences in population intervention outcome measure and indirect measure will give you the indirectness in the study. Last point which we have to consider is the imprecision. Now, imprecision will be followed by certain factors. It is governed by certain factors. You have to see the number one is the study size, sample size. If there are few patients in the study, definitely the imprecision will lie there because of the wide confidence interval around the estimate of the effects. That will definitely deteriorate the quality of evidence. Publication bias. Publication bias means bias in while publishing your article, bias in the publication, and it is governed by various factors. Number one is the study size. Definitely a study having a large sample size, the chances of their publication is more as compared to the studies which have a less sample size. Study design, it is taken into consideration that the study having the higher level of evidence like randomized control trial, clinical trial, systematic reviews, the chances of publication are more as compared to the quasi-randomized control trial or the case reports. Then the studies which have low risk of bias as compared to the high risk of bias, the chances of publication increases with this risk of bias also. This publication bias is detected by the asymmetry in the funnel plot. While you have read about the meta-analysis, two types of plots were discussed. One is the forest plot, another is the funnel plot. Forest plot will give you the results of meta-analysis in the form of the effect size through a software Revman, or you can also use the Cochrane tool for that. And the funnel plot, the asymmetry in that funnel plot will provide you the publication bias. But here I would like to mention that asymmetry in the funnel plot will give you only the qualitative analysis of for the publication bias, not the quantitative analysis. For quantitative analysis, you have to go for agar regression test so that you can quantify what amount of publication bias lies in the studies. Next, the factors which can enhance your quality of evidence. Number one is the large magnitude of your effect. The effect size is given by Cohen d value. Zero point 0.2 is the small effect size, 0.5 is moderate, and 0.8 is your large effect size. Larger the effect size magnitude of effect, the larger will be your chances for upgrading the estimate of the effect. Lastly, the last factors to be considered is the dose gradient response. The studies which give the relationship, which give the results with the dose are definitely having the high quality of evidence. Example, if we are seeing the dose response gradient between the warfarin measured by our INR and the bleeding risk. So if yeah, supposingly we are seeing the effect of certain NSAs on the post-operative pain, if they are considering the doses of NSAs in giving the outcome in the form of post-operative pain, that study will definitely have a good quality of evidence rather than those studies which are not mentioning about the dose response of NSAIDs in achieving the post-operative pain. Now, here we end with the quality of evidence and a little bit information about the recommendations. Recommendations can be, again, I would like to repeat here that recommendations are mostly made by the guideline makers and the policy makers because they have to consider certain other parameters apart from quality of evidence for making the recommendations. Those parameters I will be discussing very soon. So the gray recommendation can be in the form of strong or it can be the weak recommendation. What do you mean by strong recommendation? Strong recommendation means your desirable effects outweighs your undesirable effect. And weak recommendation, which can be another term can be said to be conditional, discretionary, means your desirable effects are likely outweigh the undesirable or less likely to outweigh the undesirable effects. That is your weak recommendation is there. So what are the factors which guideline makers or the policy maker consider while making the recommendation? Number one, the most important factor is the balance between the desirable and undesirable effect, means the good and the bad harmful effect is there. Number two is your quality of evidence. Quality of evidence is secondary to your desirable and undesirable effect. Number three is your values and preferences of the patient towards the treatment or towards the intervention. What are the preferences of the patient? They consider the preferences of the patient while considering the considering while making the preference of the patient towards the intervention or towards the treatment while making the recommendation. And lastly, that is very important point, that is the higher cost, that is the cost involved in the intervention or the treatment. The higher the cost of an intervention, there are less likely to recommend a strong recommendation. These are the symbolic representation for the quality of evidence and the strength of recommendation. Quality of evidence can be given by a plus sign or a capital alphabetical order, high with the 4 plus sign and very low with the 1 plus sign. And the strength of recommendation can be given with the symbolic sign of arrows, upward arrows or the downward arrows, or by the number 1 and 2. Here, one important point is that it is not at all necessary that if a study, if a systematic review have a high quality of evidence, it must possesses a strong recommendation. It is not like that. That is why the authors always go for quality of evidence. They never make the recommendation. This is explained by example. This has been proven by the high quality evidence study that the combination of chemotherapy and radiotherapy for the treatment of lung cancer is having the high quality evidence on the basis of the study design or the type of studies. But the guideline makers give it a weak recommendation because of the associated risk factor, harmful factors associated with the chemotherapy, and also associated also the values and preferences of the patient towards the chemotherapy. So a high quality evidence study systematic review can also have a weak recommendation. Vice versa, a strong recommendation can be based on low or very low quality evidence of systematic review or studies. The use of antibiotics in the severe infection or sepsis has been given a low quality of evidence based on various observational study. But guideline makers give it a strong recommendation because of the clear benefits of the antibiotic therapy as compared to the undesirable effect given by the patients, reported by the patients. So, advantages of GRADE. GRADE is developed by the global guideline expert. It gives you a clear distinction about the estimate of confidence and the recommendation of strength. It tells you about the importance of various outcomes in making the decision. It tells you the clear cut criteria or the factors which can downgrade or upgrade your quality of evidence. A transparent and stepwise process from evidence to recommendation, and also it considers the values and preferences of the patient towards the treatment or towards the intervention. So I will explain how to apply the grade on Grade Pro GDT with an example. This example has been taken from the Journal of Endodontics. The title of the paper is Effectiveness of Intracanal Cryotherapy in Root Canal Therapy, a systematic review and meta-analysis of randomized clinical trial. So here the PICO is population, that is patients are the adults with pulpal and periradicular pathosis. Intervention is your intracanal cryotherapy. Comparison is your standard care. And outcome is in the form of post-operative pain in the form of mean plus में standard deviation, plus minus में standard deviation. And the study design, your studies are randomized clinical trial. So now I will apply the example, this example on Grade Pro GDT. And before that, I would like my mentors I would like to say thank you to my mentors, that is Dr. Jigyasa Duhan and Dr. Vivek Agarwal, for always motivating me. Now we will apply this example on Grade Pro GDT. For applying this example on Grade Pro GDT, you have to create a RevMin file for any example which you are taking into consideration. So before applying the example on Grade Pro GDT, one has to consider creating a RevMin file, and one have to log in through Grade Pro GDT by creating an account over Grade Pro GDT. So we will apply this example on Grade Pro GDT. When you log in through Grade Pro GDT, you will get this window. You have to import your project. You have to choose your RevMin file. So this is the RevMin file which I have already created, effectiveness of intracanal cryotherapy in controlling the pain. You have to select your PICO and you have to import your project. This project has been imported successfully. Now you have to click your question. So you will get a table of quality of evidence like this. On this question, that is, should post-operative pain among control and cryotherapy control the post-operative pain at 6 hours? It contains number of studies 4. Now you have to give the study design as mentioned in the article. All the studies which are included in this systematic review were randomized clinical trials. So you have to apply randomized clinical trial. Next is risk of bias. Risk of bias reported in this study was serious. You have to add the explanation here that in the current present systematic review, the risk of bias was high. Now you can assess this risk of bias over here. That grade assessment of study limitation. Most of the studies were having low or unclear risk of bias. It has been already mentioned in the article. Then consideration, that is, potential limitations are likely to lower the confidence in the estimate of effect because your studies are having high risk of bias. Sorry, here you have to click high risk of bias. Next is final decision is your risk of bias is serious. You have to apply this. You have to give reason for each and every parameter. Next is your inconsistency. Inconsistency in this parameter was serious because the value of heterogeneity was 76%. So you have to add reason here. Value of I square is 76%. Next is your indirectness. Indirectness was not serious in this systematic review. There was no difference in the population intervention comparison. Imprecision. Imprecision was also not serious in this because the effect size came out to be 0.79, which is a good large effect size. Population size were also pretty good, that is 380. Other consideration which has to be taken into account is the population publication bias. It was undetected in the study. Effect size was large. Plausible confounding factors were undetected, so no plausible confounding factor, and it was not a dose gradient response study. You have to apply this. So now you got your quality of evidence as moderate, and you have to give the grading to your outcome. Since the post-operative pain was important in this study, so you have to give a rating of critical. So this is how you apply grade in a software. And here the quality of evidence came out to be moderate. This moderate quality is also mentioned in the article while applying the grade. It has different outcomes. So you have to apply for each and every outcome grade. Now you can save this file. Great. This is the quality of evidence came out to be moderate over a critical outcome. And for the recommendations, these are the points you have to consider for the recommendation, or the guideline makers will consider these points while making the recommendation. First is the problem a priority? Next is your desirable effects, which is one of the important factor to consider while making the recommendation. Undesirable effects, certainty of evidence, that is your quality of evidence. Here it comes out to be moderate. Then the values and preferences of the patient towards the treatment. What is the balance of effect between the desirable and undesirable? What is the cost of the treatment involved? What is the certainty of evidence for the required resources? Cost effectiveness, health equity, acceptability of the treatment, feasibility of the treatment, and then you can get easily here the summary of judgment based on your these parameters, and you can easily save this through this in the MS Word, PDF, whatever you want.